Usually, when we think about our bodies breaking down, we tend to imagine, a clean, sudden break.
Right, like a snapped bone or a torn muscle.
Exactly, like a machine where a gear just suddenly falls out. But what happens when the central engine of the body, the heart, doesn't just stop, but starts to slowly, well, sputter?
Yeah, that's when things get really complicated.
Yeah.
Because you're looking at a system that is so complex, so highly tuned, that when it starts to fail, literally the entire body gets dragged into the drama.
It really does. And welcome to today's deep dive, where our mission is to decode some absolutely fascinating clinical medical notes all about the cardiovascular system.
And just to set the stage for you listening, we aren't going to focus on, where these notes came from or who exactly wrote them.
Right, we're skipping the origin story.
Exactly. Our target today is the pure, unfiltered physiology contained within them. We're looking at the completely counterintuitive ways your heart, your brain, and your blood vessels communicate when the system goes critical.
It's wild stuff. So, okay, let's unpack this. Because the very term we are starting with is honestly a massive misnomer: heart failure.
Oh, absolutely.
I mean, to anyone outside the medical field, it sounds like a sudden catastrophic stop. It implies like the electrical system just shorts out and the muscle quits right then and there.
Yeah, but the clinical reality is far more of a grinding systemic decline.
Yeah.
Heart failure isn't a single event. It's a physiological syndrome.
A syndrome.
Right. It is defined fundamentally as a supply and demand mismatch.
Okay, break that down for us.
So the heart is receiving an adequate venous return, meaning blood is arriving at the station just fine, but the muscle is unable to maintain the tissue perfusion required by the body's metabolic demands.
So the engine is still running, but the output is just fundamentally compromised.
Precisely. It's a pump problem, not a stop sign.
Yeah.
And these notes break this down into two very distinct mechanical failures. You've got systolic and diastolic dysfunction.
Right.
In systolic dysfunction, which is also called heart failure with reduced ejection fraction, we're looking at a primary failure of contractility, or inotropy, to use the medical term.
So the heart essentially loses its squeeze.
Yes. The myocardium, the heart muscle, has lost its squeeze. This is the classic aftermath of, say, a massive heart attack.
Oh, I see. Because a portion of the muscle actually dies.
Exactly. A significant portion of the viable muscle tissue has necrosed. It dies and gets replaced by fibrotic scar tissue, and scar tissue simply cannot contract.
Wow. So the pump chamber itself is physically compromised. The remaining healthy muscle is what, trying to do the work of the entire left ventricle?
Yeah, and it just can't generate the pressure necessary to clear the chamber.
That makes total sense. But the second type, the diastolic dysfunction, that one is almost more insidious, isn't it?
It really is. That's heart failure with preserved ejection fraction. Because here, the problem isn't the squeeze at all. It's the filling.
Right. The ventricle in a diastolic failure scenario has lost its compliance. It gets stiff.
Spot on. We see this constantly with severe left ventricular hypertrophy, which is usually driven by chronic high blood pressure.
Because the heart muscle has spent years basically weightlifting against that high systemic resistance, so it bulks up.
Right. The ventricular wall becomes incredibly thick and stiff. And what people often don't realize is that relaxation during the diastolic phase, when the heart is filling, isn't just passive. It actually requires energy.
Oh, interesting.
Yeah.
Huh?
And a thick fibrotic ventricle simply cannot relax and expand to accommodate a normal volume of blood.
Wait, so with diastolic failure, the heart is still pumping out a normal percentage of the blood it holds, but it's failing because the tank itself shrunk?
That is exactly it.
I always picture this like trying to fill a stiff, dry water balloon versus like a really highly elastic one.
That's a perfect analogy.
You can squeeze that thick, stiff rubber balloon just fine, right? And you can empty most of its contents. But because it couldn't stretch in the first place, you barely got any water into it to begin with.
Yes. And the math here creates a fascinating diagnostic illusion for doctors. The formula for ejection fraction is stroke volume divided by N diastolic volume.
Okay, so the amount pumped out divided by the total amount inside.
Right. In this hypertrophic, stiff heart, the stroke volume, the amount pumped out, is terribly low because the chamber couldn't fill. But the end diastolic volume, the total amount inside, is also artificially low because the chamber is so stiff.
Ah, so the denominator shrinks right along with the numerator.
Exactly. As a result, the calculated percentage looks completely normal. It might be 60 or 65%, which on a chart looks perfectly healthy.
That is wild. The math is quote-unquote preserved, masking the fact that the actual absolute volume of blood reaching the brain and kidneys is dangerously low.
Right. It requires a clinician to look past the isolated percentage and understand the actual plumbing of a stiffened pump.
Which brings us to the inevitable physical consequences of a failing pump. Because if the cardiac output drops, but the venous return, the blood coming back, remains steady, well, that blood has to go somewhere.
Yeah, we're dealing with a closed hydraulic loop here.
Right. If the pump can't move the volume forward, the pressure has to propagate backward. It's a traffic jam that physically manifests in your tissues.
And the manifestation depends entirely on which side of the pump is failing. Remember, the heart is essentially two pumps in series.
Left and right.
Exactly. So let's trace the retrograde pressure of left heart failure first. Whether that left ventricle is weakened by ischemia or stiffened by hypertrophy, the pressure inside it at the end of filling the left ventricular and diastolic pressure rises sharply.
And that pressure doesn't just stay confined to the ventricle, does it?
Nope. It transmits directly backward, first into the left atrium, and from there retrograde right into the pulmonary veins.
So a left-sided mechanical failure actually turns the lung circulation into a high-pressure reservoir. The left heart is basically a clogged drain, and the lungs are the sink that's overflowing.
That's horrifying, but
Ugh.
perfectly accurate. And the biophysics of that overflow are brutal.
How so?
Well, as the hydrostatic pressure inside the tiny pulmonary capillary beds spikes, it eventually overwhelms the normal forces that keep fluid inside the blood vessels.
Oh, I see where this is going.
Yeah. Plasma is physically forced across the vessel walls and into the interstitial spaces of the lungs, and eventually into the air, sacs the alveoli themselves. This is acute pulmonary edema.
The delicate, super stretchy lung tissue becomes heavy and boggy.
Exactly. It becomes incredibly stiff. Gas exchange just plummets because oxygen now has to physically diffuse through a layer of fluid.
And the clinical signs of this are just harrowing. The notes highlight orthopnea, which, when you think about it, makes perfect mechanical sense.
Right. Breathlessness when lying flat.
Yeah, because when the patient is upright, gravity keeps all that excess pulmonary fluid pooled at the bases of the lungs, so their upper lobes are relatively clear for breathing.
But the moment they lie flat,
That fluid redistributes across the entire surface area of the lungs. It's essentially drowning them from the inside. It's terrifying. And it's not just plasma leaking. The notes mention this classic, albeit grim sign, coughing up pink, frothy sputum.
oh, wow. Pink because of blood.
Yes. The pressure in those tiny pulmonary capillaries gets so intensely high that the vessels undergo mechanical shear stress and actually rupture.
Yikes.
Yeah, so it mixes whole blood with the edema fluid and air. It is a profound physiological crisis.
Okay, so that's the left side destroying the lungs.
Yeah.
What about the other half of the system? Right heart failure must paint a completely different picture.
It absolutely does. And often, right heart failure isn't even primarily a cardiac issue to begin with. It's a consequence of a lung problem.
Wait, really?
Yeah. In conditions like severe COPD or pulmonary arterial hypertension, the vascular resistance in the lungs skyrockets.
Okay.
So the right ventricle, which is relatively thin-walled because it's only designed for low-pressure system, suddenly has to pump against massive resistance.
Ah, so it's being forced to do the job of the heavy-duty left ventricle, but without the anatomical bulk to actually handle it. Precisely. So the right ventricle eventually dilates and fails. And the retrograde pressure path from the right side of the heart skips the lungs entirely.
Because it's before the lungs in the circuit.
Right. The pressure backs up into the right atrium and then directly into the superior and inferior vena cava.
The main veins of the body.
Yes. So we see massive systemic venous congestion. The hydrostatic pressure spikes in the capillary beds throughout the entire body.
Which means the fluid leaks into the peripheral tissues. This is where you see that bilateral ankle edema, right?
Exactly. Gravity pulls the fluid down into the lower extremities, causing massive swelling in the ankles and legs. But the internal organs take a huge hit too, particularly the liver.
Oh, right, because the hepatic veins engorge.
Yeah, they swell up, which actually stretches the liver capsule. The notes mention hepatomegaly, an enlarged liver, and that capsular stretch is what causes the severe right upper quadrant pain these patients often feel.
That's fascinating. So the blood pools in the body, causing ankle swelling and liver pain.
And the architecture of the liver actually begins to change under that chronic pressure, which can lead to cardiac cirrhosis.
Here's where it gets really interesting to me. A lung problem, like COPD, can actually break the right side of your heart, while a left heart problem will drown your lungs.
It's a perfect illustration of how no organ exists in a vacuum.
Right. But, listening to this, You'd assume an organism as evolved as a human being would have sophisticated fail-safes for this. Like, if tissue perfusion drops, shouldn't the body recognize the heart is failing and try to, I don't know, offload the stress?
You would think so,
Yeah.
but the compensatory mechanisms the body deploys actually accelerate the destruction.
The fix becomes the villain.
Exactly. The evolutionary fix is fundamentally flawed for this specific mechanical problem. It starts with a localized response called the Frank-Starling mechanism.
Okay, how does that work?
In healthy physiology, an increased venous return stretches the heart muscle fibers. This stretch optimizes the alignment of the muscle proteins, resulting in a more forceful contraction.
So normally, the more it stretches, the harder it snaps back.
Right. It's an elegant, intrinsic way for the heart to match its output to its input. But in a failing, dilated heart, those muscle fibers are stretched far beyond their optimal length.
Ah. They're overstretched, like a rubber band that has completely lost its elasticity. Stretching it further doesn't create more snap, it just makes it flappy.
That's exactly what happens.
Yeah.
So the intrinsic mechanical fix fails, cardiac output continues to fall, and the systemic alarms are tripped.
Enter the brain and the kidneys.
Yes, the brain detects the drop in blood pressure and instantly activates the sympathetic nervous system.
The fight or flight response.
Yep. It floods the heart with adrenaline, basically forcing it to increase heart rate and contractility. It is whipping an exhausted horse, forcing a compromised, oxygen-starved muscle to work exponentially harder.
Which sounds like a terrible idea.
It is. And simultaneously, it causes widespread vasoconstriction. It clamps down on the blood vessels.
So it's clamping down on the pipes to force the pressure up? But by doing that, it's massively increasing the resistance the dying heart has to push against.
Exactly. It's a terrible strategy. But the kidneys launch an even more destructive cascade.
The RAAS system, right?
Yes, the renin-angiotensin-aldosterone system. You see, the kidneys are entirely dependent on high-pressure perfusion to filter blood. When cardiac output drops, the kidneys interpret this drop in pressure not as a failing pump, but as profound blood loss.
They think we're bleeding out.
Right. The kidney assumes you are bleeding to death in a desert. Its sole mission becomes preserving fluid volume and increasing vascular tone. So it secretes a hormone called renin.
And this kicks off that whole RAAS cascade.
Exactly. Renin eventually leads to the production of angiotensin II, which is an absolute powerhouse of a molecule. It drives an even more profound systemic vasoconstriction than the sympathetic nervous system.
But wait, its secondary effect is arguably worse, right?
Yeah.
Because it stimulates the adrenal glands.
Yes, to dump aldosterone. And aldosterone commands the kidneys to reabsorb sodium. Where sodium goes, water follows.
So the kidneys essentially stop excreting free water, aggressively expanding the amount of fluid in the bloodstream.
Yep.
It's like a sinking ship. It's like the body detects a drop in water pressure from a failing pump, so it decides to constrict all the pipes and pump more water into the system. Doesn't that just drown the already exhausted pump?
It absolutely does. It raises venous pressures and causes even more edema. The compensatory mechanism is literally drowning the pump it's trying to save.
So how do we survive this? Doesn't the heart fight back?
It does try. As the heart walls are subjected to this massive volume overload and stretch, the muscle cells release counterregulatory peptides, primarily ANP and BNP.
Brain natriuretic peptide.
Exactly. These peptides are the heart desperately trying to override the kidneys. They promote vasodilation, opening the pipes, and force the kidneys to dump sodium and water into the urine.
It's basically the heart's internal countermeasure, like a diagnostic SOS marker.
Right. And clinically, BNP is an invaluable marker. If a patient comes into the ER struggling to breathe and they have radically elevated BNP levels, they're almost certainly experiencing an acute exacerbation of heart failure.
The stretch receptors are screaming for help.
Yes.
And, understanding this flawed cascade completely demystifies modern medical treatments for heart failure.
How so?
Well, we aren't really treating the heart muscle directly in most cases. We are chemically restraining the kidneys and the nervous system.
That's a great way to put it.
We use beta blockers to stop the sympathetic overdrive. We use ACE inhibitors to block the RAAS vasoconstriction. And we use diuretics like furosemide to dump the excess fluid. The entire medical strategy is just stopping the body from helping the heart to death.
Exactly. We are actively suppressing the evolutionary survival reflexes to buy the compromised heart some time and reduce its workload.
It's incredible. But, there's a fascinating symmetry in these notes. We just explored how the body's pressure management system slowly, chronically strangles the heart over years. But the source material also dives into how that exact same pressure system can pull the plug in a matter of seconds.
Ah, yes. Syncope.
Let's shift from the chronic failure of perfusion to the sudden, acute collapse of it. What exactly is syncope?
Syncope is a transient loss of consciousness, accompanied by a loss of postural tone, meaning you fall over. And it's driven by a sudden, critical drop in global blood flow to the brain.
Because the brain is uniquely intolerant of a lack of oxygen.
Very. If cerebral blood flow ceases for even 6 to 8 seconds, consciousness is lost. And the underlying causes can be anything from lethal heart arrhythmias to neurological issues like seizures or even medication side effects.
But the notes spend significant time on the mechanics of orthostatic tolerance. Basically, how just standing up is a massive hemodynamic challenge.
It really is. The moment you move from lying down to standing up, gravity dictates that a huge amount of blood, roughly 500 to 800 milliliters, immediately pools in the veins of your legs and your abdomen.
So the blood returning to the heart drops instantly.
Right. Consequently, cardiac output and blood pressure fall. In a normal, healthy system, sensors called baroreceptors in your neck and chest detect this drop within milliseconds.
And they fix it.
Exactly. They ramp up the sympathetic nervous system. Your heart rate increases and your blood vessels constrict to push blood up from your legs and back to your core, keeping your brain perfused.
So we have this highly tuned millisecond responsive reflex keeping us conscious every time we stand up. Let's look at vasovagal syncope, where this exact reflex gets its wires spectacularly crossed.
Oh, this is one of the most bizarre paradoxes in human physiology.
Right. The classic triggers are emotional stress, extreme fear, or severe pain. Walk us through the mechanics of a vasovagal episode.
So let's say a person experiences extreme emotional distress or pain. The initial phase is a massive sympathetic surge. Adrenaline spikes, the heart is racing, contractility is peaking, the body is preparing for fight or flight.
Okay, makes sense.
But if this hypercontractile state occurs when the ventricular chamber is underfilled, say because you've been standing in the hot sun for an hour and the blood is pooled in your legs, a bizarre mechanical trigger is tripped.
Because the heart is squeezing incredibly hard on a mostly empty chamber.
Precisely. The vigorous contraction on an underfilled ventricle aggressively stimulates stretch receptors in the heart wall. Normally, these sensors only fire when the heart is dangerously overfilled or the blood pressure is sky high.
So the sensors detect the aggressive wall tension from the empty squeeze, and they misinterpret it as severe, life-threatening high blood pressure.
Yes. The sensor array literally lies to the brain. The signal hits the brainstem, and the autonomic nervous system violently overcorrects. This is called a Basal-Gerish-like reflex. The brain instantaneously withdraws all sympathetic drive and unleashes an overwhelming surge of parasympathetic activity via the vagus nerve.
It's an autonomic whiplash. You go from maximum fight or flight to a sudden massive crash.
Exactly.
Yeah.
The sudden drop in sympathetic tone causes profound vasodilation. The blood vessels basically open the floodgates. And simultaneously, the massive vagus nerve surge hits the heart's pacemaker, causing severe bradycardia. The heart rate falls off a cliff.
So you have widespread vasodilation coupled with a drastically slowed pump.
Which is catastrophic for cerebral perfusion. Blood pressure drops below the minimum threshold for the brain, the cerebral cortex is deprived of oxygen, and you lose consciousness and collapse.
So what does this all mean? The irony is just incredible. Your body perceives an external threat like fear or pain. It attempts to hype itself up to survive. But because of a mechanical quirk, it crosses its wires, tricks its own nervous system into thinking the blood pressure is dangerously high, and it literally pulls the plug on your consciousness.
It is a remarkable failure of evolutionary design.
Yeah.
However, and this is the crazy part, from a purely mechanical standpoint, fainting is highly effective.
Right, because by forcing you to the ground.
Exactly. By forcing the body into a horizontal position, gravity no longer impedes venous return. The blood that was pooled in your legs rushes back to your heart, cardiac output is restored, and you quickly wake up.
Fainting is essentially the body's most aggressive, non-negotiable mechanism for forcing you flat on the ground to fix your venous return. It's crude, but it works.
It really does.
It really brings everything we've explored today full circle. Well, we started by breaking down heart failure, right? Examining how it isn't just a simple mechanical plumbing issue, but a complex syndrome made exponentially worse by the body's own hormonal panic. the RAAS cascade, and the sympathetic nervous system.
Right, the body trying to help, but actually drowning the pump.
Exactly. And then we looked at syncope, where fainting is sometimes just a bizarre neurological crossed wire.
Yeah, the underlying theme of all these clinical notes is really the double-edged sword of physiological homeostasis.
Yeah.
The human body possesses incredibly robust, tightly regulated feedback loops designed to maintain blood pressure at all costs. But treating the heart is really about outsmarting the kidneys, the brain, and the blood vessels to stop them from overhelping.
Because they react to a failing fibrotic heart with the exact same blunt force tools they use to react to a massive hemorrhage.
Exactly. They are remarkably blind to the underlying pathology.
Which leaves us with a profound, lingering question. If human beings evolved these incredibly complex, highly sensitive compensatory mechanisms to keep us alive during prehistoric crises,
Like massive blood loss from a predator attack.
right, where aggressively clamping down on blood vessels and hoarding sodium were literal superpowers, is the modern tragedy of heart failure simply the cost of our bodies trying to apply a caveman survival tactic to a modern chronic disease?
That's a great point. The body thinks it's bleeding to death on the savannah, but the engine is just quietly sputtering out.
Exactly. Something to mull over. Until next time, keep diving deep.